All right, now we are going to talk about anesthetics. So let's get into it here. Not that long of a lecture. There's going to be some drugs that are repeated. Just kind of with the neurology module in general, you guys are going to notice there's a lot of little lectures. It's just kind of the way it is. I don't know. We used to do the psychotherapeutics and all the psych drugs during this module, and it was insane. It was a ton of stuff. It still is a lot of stuff, but hopefully now with these smaller lectures, the neurology module won't be as hard as it was in the past. So I just want to give you guys that warning too, that this is a difficult module historically, meaning the students have had trouble with this module in the past. I think part of that was related to all the psych drugs being jammed in here. But now we have pharmacology 3, so all those psych drugs are going to be in the summer, so I think that'll help you guys. But anyway, so just general warning, just please study, spend some time with these drugs, make sure you know how they're categorized. Some of these you will see that are in this lecture today that we've already talked about. They overlap and they're in other sections. And then the other thing too, just in general, when you're talking about anesthesia, that this is typically a lot of these drugs you guys won't necessarily be prescribing, because it's usually and most physicians don't prescribe, because it's usually just for the anesthesiologist. They're the ones that do it, or the CRNAs, I think they are. They're the nurse anesthetists. I forgot their initials, but the nurses that that will do anesthesia too. I still want you guys to pay attention to these drugs and study them. There are some ones that you guys are still going to be prescribing, still seeing. And then too, it's just good to know if you see some of these drugs on a person's chart, you know, what they're used for, or why they might be using it. But anyway, so goals about balancing anesthesia. This is just an FYI tape, not table, FYI slide. So let's just get that out there. Sorry about that. Have a little bit of a cold here, so hopefully I don't sound too funky, but try not to cough again and blow your guys' eardrums out. So we have the inhaled and the parenteral. Like I said, not going to be prescribing these a lot, but definitely, I mean, some of these you can. So like lorazepam, midazolam, you guys will probably be prescribing. You might see some patients on fentanyl, nitric oxide maybe. But anyway, so let's get into them. All right, this slide here is just FY from my course, so just read through it just to make sure everyone has similar background on the same page. Same thing here. I won't be pulling specific test questions from this slide, but it is something that you could, you know, read through. It's got some good stuff. It may be beneficial for ICM. This one too is I think it's a good table to compare some of these inhaled anesthetics, excuse me, tongue tied there. And so I think they're good. The only thing that I would pay attention to for my class is here, effect on kidney and liver. You know, if it's hepatotoxic or nephrotoxic, pay attention to that. The rest of this stuff, the MAC, blood gas partition, rate of induction, all of these you do not need to worry about. But actually, so let's draw a line here on your table, and it is good to pay attention to these two columns from testing purposes for me. Want you guys to know about the effect on the cardiovascular system, and if it has one or has any, and then the effect on liver and kidney. So those will be important for my class. But in the past, students have kind of freaked out. They thought I was going to do blood gas partition, coefficient stuff. No. Like I said, if maybe ICM, I'm not sure exactly what they're going to be testing over this year, but for my course, pay attention to these two. Whoa, the thing just got really big. Y'all see that? The pointer just got super big. Or maybe I'm hallucinating because the cuffs are up. No, I'm joking. Okay. This one too, just FYI, don't work for my test purposes. Don't stress about that slide too much. All right, so now we get into the drugs. I want you to pay attention to this. Nitric oxide. So this is the only gaseous anesthetic used. This is the one that, you know, you may hear people call it laughing gas or whatever. Maybe have experienced it within your dentist office, or some dentists used to use it. I don't know if they still do. I haven't been in the dentist for a while. And this is one too that's unfortunately sometimes abused. I know it's popular in Great Britain. I just saw a documentary on it recently. That's the reason I know. I haven't been to the UK or anything, but apparently kids there like to use this recreationally, but they call it nitrous. But anyway, so yeah, don't do drugs, kids. But Yeah, so read through this. Kinetics, don't worry too much about that. Here are some uses. Definitely look at this. Can be used in some different things. Like I mentioned, the dentist, dental procedure. That's kind of what I think of it, but you can see it in some other settings. So you may see this on your rotations being used. Contraindications, definitely want you guys to know this. Put a star by this. Hint, test question, etc. Put a star here, contraindications. By this time of the semester, you probably know that what I like to ask test questions on, and so you're hopefully kind of seeing the pattern of where I get questions from. I try not to make my questions too random, but sometimes I have to just because it's fun. No, just because sometimes the drugs make me. That sounds really bad now that I'm saying that out loud. But just meaning that there's certain drug instances where they just have a very unique characteristic, so then I have to write a very unique question for them. But this one is not, because I mean this is just contraindications. Please know this for the exam. Volatile halogenated hydrocarbons. These are used by the anesthesiologist. These you do have to be worried about the arrhythmogenic effects, and they may sensitize the heart to that. So that's what I was saying earlier, that table, it talks about the cardiac impact. So that is something that, I want you guys to make sure you go back and study that. Hepatotoxicity, another one, highlight that. Like I said, that is something that I think that table is a good job. And then nephrotoxicity. So go ahead and study that. Excuse me. Parenteral anesthetics. So these are the ones that go, via IV. Barbiturates. So you guys hopefully remember these, and this is why I told you guys to memorize which category or which. So hopefully you've been studying by now, I guess. I don't know. And you know which ones are the ultra short acting. So the thiopental and methohexatol. So those are two that saw them in the barbiturates. So, you learn them as far as what I said during that lecture, but then you also need to think about them when you're thinking about anesthesiology. And related to their ultra short acting is that they help with the induction or for a short duration, because they are ultra short acting. So that was part of the reason I said that was important to and related to the kinetics as well. Don't stress too much about the kinetics, but I think it may help you memorize which category these fall into. And then just note too, these are not analgesic, so these do not reduce pain. They may actually make the sensitization to pain and make a person more sensitive to pain, or hyperalgesic. But that's okay, because these aren't typically given by themselves. So I had a student ask me in the past, well, that doesn't sound pleasant, and are you trying to torture your patient? No, the anesthesiologists do not like to do that. They don't like to torture people. They don't. There's no Dexter anesthesiologists that I know of out there. But these are given in combination with other medications. So these are given in combination with analgesic medications, or medications that have analgesic properties, which we'll talk about ad nauseum in the musculoskeletal module. Propofol. So this is actually kind of a famous one. It looks like milk, kind of. It's milky, it's white. I don't know if anyone's ever seen it before, but this one we had in the psych hospital. They would use for the shock therapy, the electroconversion therapy that they would do. They had this, and I don't know. And the reason I remember it looks like milk, because one of my coworkers, a technician there, Glenn, he was obsessed with, not obsessed, but he just loved drinking milk. So he was the guy that, like, not just with breakfast or whatever, whatever you think of a milk drinker, this guy just always had milk, and it was just, regular milk, nothing. Every once in a while, like strawberry chocolate, if he was feeling crazy, but that was his drink. Like, most people have coffee or Red Bull or whatever, water, but he was the only guy. He's actually the only person I've ever worked with in the pharmacy that drinks milk all day. But so this guy was really into milk. But I remember him. So we would do these. We had to go through the kits. We give these kits out to the anesthesiologist and for the psychiatrist to do this electroconversion therapy, and we would refill them. And so we'd go through and usually the technician would refill them, and then I'd come back as a pharmacist and verify that they filled it properly, and then we'd seal it and send it out to the floor to be used. But I just remember him. He's like, "Isn't this delicious? Do you just want to take a big drink of this?" And I'm like, "No, Glenn, please don't drink the propofol." But yeah, I always think of him wanting to drink this. But so yeah, that isn't, and that's not going to be on the test. But that's just the story that I have, and that's what I think of when I think of this drug. The other thing I think of, unfortunately, is R.I.P. Michael Jackson. This, in combination with the benzodiazepine, is what the coroner's report said that killed Michael Jackson. Unfortunately, so if you guys remember that, or if you were too young, you guys are in diapers back when Michael Jackson died. No, I don't know. But yeah, so this is the other thing I think of, or unfortunately have that kind of connection with. But this is used in by the anesthesiologist, and like I said, number of different procedures, and you'll probably see it in the hospital depending on your rotations and everything, or depending on where you end up working later in life. One of the advantages, it is antiemetic, so it does help prevent nausea, vomiting. But then it can also cause hypotension. Usually not a big concern because the person, again, I mean, with Michael Jackson, he was at his house and the doctor was administering this medication. So I would not recommend that for you guys, needless to say. But typically this is given in a medical setting. So like I said, the psychiatric hospital I was at, it was a, inpatient setting, and hospital settings. The hypotension is usually not a big concern just because the person is there, and inpatient setting, they're being monitored and everything, and you can correct it relatively easily. Dissociative anesthetics. So ketamine is one that unfortunately does have a street presence, so to speak, or it says street drugs. Yeah, so that is, they call it Special K is one of the names. But anyways, that may be something that you may know about, not personally know about it, but just have heard about it because it is unfortunately something that's abused. And then there's this other one, the phenylcyclidine, that's actually just used by veterinarians. It's not used on humans, but those are both considered or classified as dissociative anesthetics. Those are good at analgesia. They do help reduce pain. And they have this trance-like state, which is part of the reason that people like to abuse them. And so they have this feeling of being dissociated. So that's why they're called dissociative. So the person it's like if you've heard or have an out-of-body experience, but that's what patients will describe, and then people that abuse the drug, they like it because they kind of, some people like to have that out-of-body experience, I guess, is what. So anyway, so that helps me remember the classification. Mechanism of action. So these are going to hit the NMDA, I have to slow down to say that, NMDA receptors. So they are blockers of that take-home point. This one is, one of the good things about it is this can be good because it's that dissociative state, but they're not completely knocked out, so to speak, or completely asleep. And so this can be sometimes beneficial depending on the procedure again. And I'm not going to pretend to know what specific procedures, but this is procedures where you would actually maybe need the patient to be able to respond, to be able to say things. So here's some examples here. But so that's one of the niche uses, and you may see it being used there. So it's like, because because of its analgesic properties, the patient won't experience pain, but then they will be able to kind of still interact, hopefully. But adverse effects. So look at these here. The hallucinogens are a big undesirable effect. I hesitated there just because some people, again, they abuse these drugs because they like the hallucinations. They like to go find their spirit animal. No, I'm joking. Don't do drugs. Seriously. Don't ever do these drugs illegally. But so the hallucinations is one of the reasons that people like them. But that is one of the reasons that practitioners don't like giving them, because patients will complain that, it's one thing if you're going to try to actively seek out a street drug and have a hallucinogenic experience. It's another thing if you're not wanting to hallucinate and then you start hallucinating like crazy. So look at that. And then also the cardiac implications. Make sure you look at that and remember that. High potency opioid analgesics. So we're going to talk a lot more about these later in the musculoskeletal module, but here's a list of some that are specifically part of the anesthesiologist arsenal. And then these are great at reducing pain or blocking pain. So, and then one advantage too is that they don't have the implications on the cardiac effects. So that might be something to look at. Fentanyl, you may have heard, unfortunately, again, it's in the news as being a drug of abuse. It is one that's unfortunately part of the opioid crisis right now in the U.S. And it is something that, so just FYI, kind of heads up on that. You may have heard that as again, a kind of a street drug. It's kind of it's weird for me to say that. Because when I was in pharmacy school, it wasn't considered a street drug, but now, unfortunately, it is something you are seeing on the news and part of the opioid epidemic. Midazolam or lorazepam. So we've talked about these already. These are both benzodiazepines. You hopefully will remember. So you can, again, categorize them and think about them in those ways that we already previously talked about, but then you can also think of them in that they help with help with certain procedures, so you will see them depending on the surgeries, your rotations and everything. So those are a couple there. And then for whatever reason, midazolam always reminds me of Arnold Schwarzenegger. Yeah, because we used to do this really horrible impersonation in pharmacy school, and we'd say Midazolam, get to the chopper. So we'd always say get to the chopper. With midazolam. So yeah, I don't know if that's going to help you guys remember anything or not, but that's just my way I remember midazolam. Next, we have a Tomadate. This one is, what's the brand? Amidate is the brand name. So yeah, that's sometimes I've heard of it, or I think it was is that, but generics only on the test. But yeah, this is one that may be advantageous if you're concerned about cardiovascular effects or patients with compromised cardiopulmonary functions, but it's just general anesthesia, usually in supplementation, usually in combination with other medications. But that's another one. Pre-anesthetic drugs. So these are ones that will be given, pre-operative. So these are a pretty good list here. I would definitely go ahead and look at this. Some of these we've seen already before. We've talked about the benzodiazepines. Some we have not. Like the antiemetics, we haven't talked about too much, but those help prevent vomiting. Talk about those a little bit, but so some of these drugs you will be seeing again and see them in more detail. Like hydroxyzine is one. Definitely promethazine. We've talked about a little bit, but we'll visit that one again. So, anyways, yeah, definitely on the opioids. We'll talk about more later. But there's some different reasons to do it. Here's some reasons. They help with pain. They help the patient forget or not have a memory of it. Help with muscle relaxation, decrease vasal reflexes, and then, like I said, the emesis. They help prevent emesis or the nausea and vomiting. Local anesthetics. So these you will see even in an outpatient setting. You'll see these in clinics sometimes, just because they are good. Sometimes for little procedures you're doing out in the clinic. But as the name implies, local anesthetic means that they are locally used. So this will be something where, let's say you have to put some stitches in, you may use something like a lidocaine or some kind of local anesthetic, so a local pain reducer there. And so this is something where you don't necessarily want to, because anesthesiology or the anesthetics can be risky, or they can be dangerous, what an anesthesiologist does. So it's, if you can avoid putting a person completely under, so to speak, or giving them the full anesthesia, it is usually preferred. And then especially outpatient settings. So these clinics you're going to be rotating through, they don't have anesthesiologists working there. So they would rather just do a local anesthetic to, let's say, remove a mole or something. In dermatology clinics, they'll do a mole removal. So they'll use a local anesthetic. Kinetics. This, I normally say don't worry about the kinetic slides. This slide I do want you to worry about, or pay attention to this slide. Just know that epinephrine is something that can be used in combination. So this can sometimes be used. It's not used in certain areas, so definitely highlight this. I want you guys to know where epinephrine should not be used. So put a star by there. And route administration, they're local injections, topical applications. So this one is an important slide. Metabolism here, let's see. All right, this is an interesting slide. Read through this, but don't worry about this for testing purposes, but definitely, look through this slide. Mechanism of action, so this is an important slide. So I definitely want you to put a star by the slide. Want you to know this. The take-home point is that they cause a reversible blockade of nerve conduction. So go ahead and highlight that, put a star by that. This describes how. So, I mean, definitely read through that. Make sure you understand how the blockade occurs. And then you'll remember, too, hopefully, that lidocaine is also antiarrhythmic. So that's just kind of a shout out to this cardiovascular module. Woohoo! You guys remember that? Yeah, so shout out to the antiarrhythmic lecture. Shouting out to myself here. Sorry, getting a kick out of that. Shout out to Dr. Strong, antiarrhythmic lecture. Lidocaine, so just again, help you connect the dots between these modules. But yeah, so mechanism of action, take home point, blockade of reversible blockade of nerve conduction. Here's a visual representation for you guys who are visual. Adverse effects, definitely put a star by this. Want to make sure you guys know these. They're usually not as big of a concern because they are being locally administered. That doesn't mean that you never have to worry about it, but just relatively speaking. So, but it's going to be really patient specific too. So again, depending on if the person has already some cardiovascular issues, you know, how sensitive are you going to be with it? You remember lidocaine, for example, it is antiarrhythmic. And the sedation, et cetera, stuff too. You need it depends on the patient specifically, but generally speaking, it's kind of like with the, you know, inhaled steroids versus systemic steroids, kind of like you think like that. This is topical, local, so usually not as big of a concern. Here we have the list here, the esters. You notice cocaine is on the list. This is actually, it's a C2. It's not, it's a controlled substance. It's not used a lot, but I think it's like the, but anyway, so there are medical uses for cocaine being used locally. And these will hopefully be easy to remember because they all end in cane. So these are used for, here's some uses here, but, and then specifically cocaine too also is good for vasoconstriction. So again, depending on the procedure, you can use a little bit of cocaine on that. Just sprinkle it like fairy dust. No, I'm joking. It's used, you know, proper medical settings. I'm trying to be professional, not make cocaine jokes. But yeah, so topically, locally used. Adverse effects, again, depending on how much you're administering and, but CNS stimulation, and then there's specifically cocaine higher risk of seizures. So again, if a patient has a history of seizures or is prone to seizures, that may be a concern. And then with cocaine, if it is used recreationally by your patients, you definitely need to be worried about CNS stimulation and higher incidence of seizures, because with the procedures where cocaine is used, they use a small amount. It's not as much as it is ingested for recreational use. So anyway, so that's something to be concerned with. Amides. So these also, okay, so I said these all end in cane, which is going to hopefully help you guys, but I forgot that the amides also all end in cane. So please keep these separate, esters and amides. You'll probably have to make up a little like PTBC is esters. I don't know. I'm really bad at those little rhyme things. I was just going to try to like just do one off the top of my head, but that didn't work out. But yeah, so you guys are more creative than I am. So like Ben was pro cocaine. No, that's Ben was pro tetra. I don't know. Yeah, but anyway, so you guys are good at that. So Ben does cocaine. I don't know. That's the only thing I can think about. All right. But yeah, so you make a little rhyme or whatever. Same thing with these amides. These are, and they're probably, and actually I already have these probably online, so you guys can just search that. And but anyway, so these are the amides, again, used locally. Oh, and that was the last slide. So, and just note that I typically don't have you guys worry about kinetics, but these, because of their slow metabolism and longer half-life, they are preferred in certain instances, and so they may have a rationale to be their use. So that's why I want you guys to learn the difference between the amides and the esters, and yeah, make a little rhyme for these as well, or I don't know, whatever works for memorization. Usually, for me in pharmacy school, I would just, if I just wrote these enough, like if I just wrote amide and then I wrote this list a few times, I would link them in my head, and so that's why I was really bad at those rhyming things. But my wife in medical school, she always had to make the little rhymes and stuff. So she may actually have one. I don't know. I'll ask her about it. But so I would just write esters, and she's like, "Why do you keep writing?" And I'm like, "That's how I learn it." She's always getting annoyed with the way I studied. She said it was stupid. But I thought the way she studied was stupid. No, but I was like, "Hey, I'm learning it for the test and for life. You learn it the way you learn it." But Anyway, she likes to give me a hard time about my stupid study methods. And that's why I'm like, hey, whatever works for you, writing it, making little rhymes, whatever it is, just keep doing that. By the way, you guys are killing it on this exam, so keep up the good work. It's high average, which is great. So anyways, I will talk to you guys later. This is the last slide, even though it was a surprise to me earlier. It is not a surprise now. And please feel free to email me questions if you have anything specifically about this lecture that you are need some more information on. All right, I will talk to you guys later. Thanks for your time and attention. Bye-bye.